Thank you, Luke. Thank you, Dr. Rose. Good morning, everyone. It's always an honor to be asked to present a general session. You know, I feel like I have some expertise in a few areas of periodontics, but unfortunately for everybody out here in the audience, this is not one of them. And you have just heard an excellent presentation by Dr. Corman, who is an expert in risk assessment and that entire field. And what I'm prepared to present to you this morning is a program from the perspective of a clinician who is struggling with how, or even if, to use this information. In order to use it effectively, it needs to somehow drive treatment decisions. And I've been asked to present a program on communicating the risk of periodontal disease to patients and to referring dentists. I think that may be code for how do we get our patients to accept the treatment that we know they need, and how do we get our referring dentists to refer appropriately. Now, in order to do that, we need effective risk assessment tools. You know, that's a tall order considering the fact that we're dealing with a disease that we don't yet completely and fully understand. Yes, we've identified certain risk factors that seem to influence the initiation, the progression, and the presentation of the disease. But do these risk factors drive treatment decisions for us? You know, as a group here, we don't have a good track record when it comes to treatment protocols. This group couldn't even decide on when we should perform root planing and scaling versus surgery. But let's assume that we can assemble some objective risk assessment. The problem is when we deliver it to our patients and we deliver it to our general dentists, then these objective risk assessment tools are filtered through a whole host of subjective elements, thus the need to understand risk perception. Along with that, we need to give some thought to how we can manage these risk factors in ways that are clinically meaningful and not just with lip service. So while the areas of risk assessment, risk perception, and risk management are not clearly distinct from each other, their understanding is critical to risk communication. And risk assessment, perception, management, and communication all bring with them significant challenges, not the least of which is crafting a message about risk that our two audiences can really understand, our general dentists and our patients. So with my program this morning, I'd like to begin with what we know about risk assessment as it relates to the clinician and the patient, how that may be looked at through risk perception and how that can change health behavior, what evidence we have on risk management, and how to best communicate that. I'll conclude by trying to draw together what we know today and outline future challenges and opportunities. One of the major challenges that you and I will face when we return to our practice after this meeting is when we look at somebody like this, how do we know? Is this patient at high risk for periodontal disease, or is this patient fairly resistant? The problem is many, probably most, general dentists and a fair amount of periodontists probably equate risk with severity of disease. You look at a patient who has severe disease, and it's logical to assume that that patient is or was at high risk for periodontal disease. Or you look at a patient who has very little to no periodontal disease, and you assume they have low risk. And because of that, we've lived in a culture here where we basically treat everybody the same based on disease severity, ignoring risk patterns. But risk and diagnosis are entirely different entities. We can have a patient with the same diagnosis that requires different treatment. For example, the patient on the screen, if we know this patient is at low risk, This patient may just require some root planing and scaling and be seen maybe once or twice by their general dentist and do just fine. If this patient is at moderate risk, they may require root planing and scaling, isolated surgery, and be seen maybe every 6 months or so and do fine. If the same patient is at high risk, they may require aggressive surgery, they may require regenerative therapy, and very close monitoring to be successful. So diagnosis is very different from prognosis. And as a profession, our dental schools do a great job of teaching us a lot about diagnosis. Most of us are experts in diagnosis. We know how to probe. We know how to look at radiographs. We know about clinical attachment level. We know about bleeding on probing. All of those things tell us about diagnosis. None of those things tell us anything about prognosis. Prognostic factors are those characteristics that may predict outcome once disease is present but don't really cause it. They're the things that you and I were taught in dental school. You know, the individual tooth prognostic factors, percentage of bone loss, probing depths, distribution and type of bone loss, presence and severity furcations, mobility, crown-to-root ratio, root form, pulpal involvement, caries, tooth position, inclusive relationship, strategic value, therapist knowledge and skill, overall prognosis, age, medical status, individual tooth prognosis, rate of progression, patient cooperation, economic considerations, knowledge and ability, dentist etiologic factors. And what it's suggested is that you and I are supposed to take those particular factors as they individually relate to your particular patient, the particular tooth or dentition, and you're supposed to come up with a prognosis. Well, it wasn't until we did our series of studies in the 1990s looking at prognosis versus actual outcome that anybody had ever even looked to see whether the commonly taught clinical criteria for prognosis work. What we did was we took 100 consecutive patients in our maintenance program that had been followed from 5 to 15 years. We looked at the prognosis that I had assigned after treatment, and then we just revisited that. We looked at 5 years, at 15 years to see, okay, if I assigned a tooth with a fair prognosis after treatment, did it stay fair or did it change? And what we found is that teeth with a good prognosis tend to remain good. And about 72% of the teeth had a good prognosis. But what we also found was the teeth in all the other categories, fair, poor, questionable, and hopeless, those categories changed greatly over time. And in fact, our data showed that you would be just as successful in assigning a correct prognosis in those categories with the flip of the coin than using these commonly taught clinical parameters. So if you wanted to use prognosis to put patients in different buckets as far as who may need to be followed closely and who may do just fine with little maintenance, those patients with a good prognosis, or those teeth with a good prognosis, about 72%, you probably could be fairly safe to assume they're going to remain good. But all those other teeth that are in those other categories, they may require more maintenance. But to be clinically useful, we need to add risk to prognosis, because risk is going to influence the future of how the disease may progress. Risk factors are defined as those patient characteristics associated with the development and the progression of the disease in the first place. And we use risk in a number of ways, or at least we should. We should use risk to establish which patients are at risk before disease occurs. That would be kind of the holy grail, wouldn't it? There are a lot of our patients who are at risk for disease before there are any clinical signs or symptoms, because early disease is preclinical. We don't see that. We also use risk to personalize treatment based on the patient's unique risk profile. As Dr. Kornman was saying, this is going to be more and more important in the future to personalize disease based on that patient's disease signature. And there is literature out there to suggest that there's more patients in the population that have risk for periodontal disease that currently have it right now. For example, you can have patients who are at high risk that have no clinical signs or very little clinical signs. An example might be, say you have a 25-year-old young man, heavy smoker, poorly controlled diabetes. He may just have one little 4 to 5 millimeter probing depth that's bleeding on probing in the posterior region. And he may be at high risk. Or you could have a 60-year-old former smoker with 6 millimeter generalized probing depths in the posterior region, and he may be at lower risk. So we use risk then to try to modulate both the treatment and the prevention for those type of folks. So that young man at 25, he may require aggressive treatment and aggressive monitoring, yet that 60-year-old former smoker may require, just non-surgical care now and fairly routine maintenance. So we've got a fair amount of evidence out there, as Dr. Corman talked about, that should allow us to place patients in different buckets. Here are risk factors that we know that will influence risk of future disease and also influence response to therapy. Now, ideally, it'd be nice if these would allow us to put these people in these different stratifications before these things change and happen. Risk factors as it relates to these two areas are separate, and so we'll take them independently. And let's talk first about what we know about risk factors that influence disease development. We've done a great job over the last 40 years educating both the public and our general dentists that plaque is plaque, too much of it is bad, and everybody is equally susceptible. All you got to do is treat the plaque and everybody will be fine. But we know that's not the case. We know that bacterial plaque is essential, but you also need a susceptible host. And there's studies that show that bacteria account for really only about 20% of the variance between who's really going to progress into severe disease. If you look at all the risk factors that there's evidence for, we've got a lot of evidence out there. We know that we've got evidence for local risk factors, pre-existing disease maybe being the strongest, deep probing depths as a relationship to that, plaque retentive areas, defective restorations, and a whole host of local factors, systemic factors like poorly controlled diabetes, smoking, stress and coping behavior, osteopenia and others, and background determinants that we really can't change, things like gender, age, and genetic influences. And if we really drill down here and say, okay, there's evidence for all of these, are there some of these that come to the surface that we really should pay attention to? And it seems that these are the ones that we have the most evidence for. Those patients with pre-existing periodontal disease, poorly controlled diabetes, smoking, and genetic influences. So we know that if you have a bacterial challenge, you're going to get inflammation. But how much inflammation, how much tissue destruction, how much disease occurs depends on genetic and acquired risk factors like smoking, diabetes. So what we would like to do is we'd like to be able to identify this lady who, even though she's faced with significant amounts of plaque and calculus, really never progresses past gingivitis and mild periodontitis. Even more importantly, we would like to identify this young man who, at a very early age, has severe generalized bone loss throughout all of the posterior segments of his mouth. That's the holy grail. We want to identify these people before it happens and so that they can receive the specialized treatment that they need. Now, the Academy has been busy trying to elevate risk factors to our audience of interest. Remember, I've been tasked to talk about communication. You may remember that in 2006, the Academy wrote and published guidelines for management of patients with periodontal disease. And it was all based on co-management of patients around risk factors. The Academy received a lot of heat from this. Some of our audiences out there didn't like this, that we are proposing guidelines based on risk factors that place patients into different levels. They proposed level 3 patients are patients who should be treated by a periodontist. That's anybody with severe chronic perio, furcation involvement, aggressive perio abscess, significant root exposure, or peri-implant disease. Sounds reasonable to me. Level 2 patients are patients who would benefit from co-management with risk factors such as periodontal disease prior to 35 years old, unresolved inflammation, pocket depth greater than 5 millimeters, vertical bone defects, radiographic evidence of progressive bone loss, progressive tooth mobility, progressive attachment loss, anatomical gingival deformities, exposed root surfaces, deteriorating risk profile, or medical or behavioral risk factors such as smoking, tobacco use, diabetes, osteoporosis, drug-induced gingival conditions, compromised immune systems, and deteriorating risk profile. Again, sounds pretty reasonable to me. I doubt anybody in the audience would have issue that patients with these factors would probably it would be good to be co-managed with a periodontist. And then finally, level 1, patients who may benefit from co-management, any patient with periodontal inflammation in the following systemic conditions: diabetes, pregnancy, cardiovascular disease, and chronic respiratory disease. So in 2006, the Academy put a stake in the ground and said, listen, we need to be looking at our patients and managing their care based on risk factors. This year, the Academy also produced a new document on comprehensive periodontal therapy, and again, they emphasize the importance of risk factors as it relates to being part of every comprehensive dental evaluation, suggesting it be done every year and at every maintenance. So the Academy has really elevated risk factors. The Academy has published these for all of our audiences of interest. The Academy also has on its website a risk assessment tool for your patients. Your patients can go on the Academy website and they can answer these questions. How old are you? Male or female? Do your gums ever bleed? Have you lost teeth? Just a whole host of questions here. And at the end, out pops a risk assessment. Now, if you're over a certain age, almost everybody comes out to be highly at risk for periodontal disease. So the instrument's probably not a good risk assessment tool, but I think it's a good risk awareness tool. It helps our patients understand that periodontal disease is a disease of risk factors, and to be successful, we need to control those factors. Well, what's out there in the literature that might help the clinicians? Lang and Tonetti published a very interesting algorithm in 2003 where they looked at risk factors, trying to segregate patients into different risks based on how often they should be seen for maintenance. They suggested that we should look at full mouth bleeding score, probing depths greater than 5 millimeters, tooth loss versus age, bone loss versus age, systemic conditions, and environmental factors like plaque and calculus and smoking and such, and look at all those simultaneously, and that then would allow us to stratify patients into different risks: low risk, moderate risk, high risk. And since then, other studies, Eichholz and his group in Germany, have used this and validated that it works pretty good. And in fact, the high-risk patients have more tooth loss over time. We know that there is a computerized risk assessment tool that's out on the market. It looks at about 12 different risk factors and will allow us to stratify our patients and give a risk score. I think one of the neat things about this is it also ties the risk score to treatment suggestions. And in the future, if these risk algorithms and assessments are going to be really useful to us as clinicians, they need to be tied to treatment algorithms. And there's been an attempt to do that with this. This also is a good instrument, and it's good for patient education. The patients seem to be able to understand this, and there's reasonable evidence that this is effective. They looked at VA data where they looked at these particular risk factors, kind of like I did with the prognosis data, and then looked years later to see, okay, if you have those risk factors, what happens over time with disease progression? And there's moderate evidence that it works with patients with moderate disease as far as predicting the future. Where it may be lacking is there's limited evidence that this is effective with a patient who comes into your office with mild to no disease. Will it predict those patients? And we need more evidence along those lines. There's also a web-based risk calculator out there. This particular one looks at 20 different risk factors. It also looks at a skin reaction test to LPS, looking at inflammatory reaction, and it does a pretty good job in that it will first create a risk analysis for the dentition, and if the risk analysis is high enough, then it will allow you to create risk levels for individual tooth levels. And there's reasonable evidence out there that it's fairly effective. And I think because as we'll talk later, and Dr. Corman mentioned, that risk factors are not necessarily additive. There can be multiplicative, they can be synergistic, antagonistic, that this is a very complex situation. And that kind of situation lends itself to computerized risk assessment, to web-based risk assessment. So we'll probably see more of that in the future. There's also work being done in salivary diagnosis to allow us to stratify our patients. Will Gianobili and his group in Michigan are doing a lot of work on this. And it's my understanding that they feel that probably periodontal disease is too complex, that there'll be just one factor they'll be looking in the saliva that's going to give the patient a particular disease signature. It's probably going to be a number of factors like protein biomarkers, microbial factors, clinical factors, and they hope to have kind of a lab on a chip where they can do real-time assessment at chairside and be able to give a disease signature. Knowing Dr. Gianobili, even though this isn't ready for prime time, it will be in the future. One that is out there right now as far as a salivary diagnostic is one that looks at pathogens. It looks through PCR analysis, looks at the four-size pathogens that have been identified as being important to periodontal disease. And if you order their test, it suggests here that in this particular example that if they have these bacteria, that patient is at increased risk for attachment loss. I'm not convinced that there is a lot of information out there that you can say that if you have certain bacteria that you're going to be more at risk for future disease. I think that this type of test may be useful for endpoint of treatment, that you might feel uncomfortable that you finished treatment if you have certain bacteria left. But the evidence is questionable as to whether or not you can use these type of tests to assign risk. Of course, another salivary diagnostic that is out there that can definitely be used to look at risk for future disease is the test to look for the interleukin-1 polymorphism. It is a very interesting and confusing sometimes for clinicians test. You know, it's really not. It tells you very little to nothing about how, if you have a patient who has severe disease, how they got there. And it's confusing to us because if you have a patient with severe disease and you test them and they come back IL1 negative, you say, what's going on? Or if you have a patient who has no disease and you test them and they come back IL1 positive, and you start, questioning the test and how you're going to use it. But there's absolutely no confusion or the evidence is clear, I should say, that patients who are IL-1 positive are significantly more likely to have moderate to severe disease. There's over a decade of evidence out there suggesting that these people are going to have a hyperinflammatory response to the bacterial challenge. The question is, how do we use that clinically? And that's where it's been difficult in the past. In our office, if we have a patient who has a positive test, especially in a compromised patient, that's going to dictate more careful monitoring, more frequent recare visits, and aggressive reduction of the inflammatory burden, as Dr. Corman suggested in one of his last slides. It's my understanding that there is a study that is now ongoing in Michigan that I'm hopeful will allow us a better understanding to the clinical utility of the IL-1 polymorphism. It's a large insurance database type study where they have brought back 4,000 patients who have been on this insurance or in this insurance database for over 15 years, and they're looking at the major risk factors that we know affect disease, looking at smoking, past history of disease, diabetes, whether they're IL-1 positive or negative. And what they're hoping to be able to come to is to further personalize care, to customize care based on outcome. And by looking at, okay, again, it's kind of like we did with the prognosis thing. You look initially and say, we've got these risk factors. Then you look way down the road. You know, because this has been in an insurance database, what treatment they have received in the interim, and here's the outcome. So are there some patients that really don't require much treatment and that bears out into good outcomes? And are there other patients who, if they have these risk factors and they didn't get appropriate treatment, is the outcome lousy? On the other hand, if they got certain treatment, was the outcome good? So hopefully it'll allow us to have a better understanding of how we can use this to customize the care that our patients need. Now, we also know that risk factors influence response to therapy. This was a shocking discovery to me in private practice. I discovered this at about 5 years when some of my patients started not responding as well as I thought they should. You know, I knew from my residency that happened to some people, but those people weren't treated by me. Yet I'm seeing some of my patients not responding as well as I thought that they should. That led me to begin to kind of rethink, what does predictability mean? I used to think that predictability means hitting that bullseye every time. And certainly that's a goal. But now I better understand that predictability really means our ability to predict. And based on the risk factors that our patients bring to us, it allows us to better predict the outcome that they should achieve. So if we know that odds are I'm going to hit that outer ring and not the center, if I can predict that ahead of time based on the risk factors they come in with, to me, that's predictable. We found when we looked at in one of our prognosis studies, when we looked at our population and we did the IL-1 test on them, we found that IL-1 positive patients were 2.7 times more likely to lose teeth. Smokers were 2.9 times more likely to lose teeth. IL-1 positive smokers were 7.7 times more likely to lose teeth. So it wasn't additive, it's multiplicative what happens when you have certain of these risk factors together. Tanetti and Cordellini have done a lot of work trying to say, okay, we know there's a lot of variability in outcome as it relates to regeneration. Why is that? And they've looked at different risk factors that the patient brings to the table, different risk factors that the defect brings, probing depth, radiographic angle of the defect, a whole host of factors including surgeon skill, and come up with treatment algorithms, decision trees that not only hopefully allow you to get a better outcome, because if you control those factors you should, but also allow you to predict what should happen. Dr. Corman mentioned some of the classic literature that we've seen over the years that patients do not all respond to the same way to treatment. Hirschfeld and Wasserman found that their maintenance patients were clearly delineated into these three groups. Wouldn't it be nice if we could evaluate these people prospectively, if we could identify that downhill group before they happen? Well, can we do that? I don't think we're quite ready to say we can do that, but there's a lot of evidence out there that the risk factors that I just went over and the prognostic factors and the ones that Dr. Corman went over, yes, should help us be able to determine which patients are going to be at greater risk for disease development and which patients are going to respond well or not respond well to therapy. Do we have distinct treatment algorithms that are linked to that? No. And it's up to you to decide, do you want to use computerized programs, web-based programs? Do you want to do this, on your own? But I think if we go back to the questions that I asked at the beginning, and that is, do these risk factors have clinical utility? We know there's evidence, but can you go back to your practice and drive treatment decisions with them? Can you use risk assessment in a way to stratify your patients? And I think, again, the answer is, yeah, probably. If you consider smoking, diabetes, age, I1 polymorphism, bleeding and probing, presence of periodontal disease, past history of periodontal disease. The evidence is clear that these patients are going to be at higher risk and are not going to respond as well to our therapy. Now, if my lecture was on telling, we'd be over. But my lecture is supposed to be on communication. And unfortunately, communication is just as complex as periodontal disease is. Now it gets really tricky, because now we've got to take those objective, evidence-based risk factors and communicate that to our two audiences. Now it gets tough, because those are going to be filtered through our patients and our general dentists' beliefs, attitudes, judgments, and feelings. These are built up over years and influenced by their social networks. They're going to, as far as the patient, going to be influenced by their significant others. They're going to be influenced by their past experiences with dentists. It's going to be influenced by colleagues and consultants that are coming into their office. It's very complex. And one of the most difficult things for you and I is that we have gravitated to periodontics because we like the evidence. We like the facts. Well, I've got some sad news for you. We were all taught in dental school, if we can provide our patients information that's clearly understood, that's clearly in the best interest of them, that they will alter their behavior to conform with that information. That generally will not happen. That's a cognitive approach to a behavioral issue, and it doesn't work that way. And there have been many studies to show that decisions are based primarily on emotions and not facts. Most people move to action based only on 5% facts and 95% of emotions. And for you and I to get our general dentists or our patients to act on these objective risk assessments, we're going to have to identify their main emotional motivator. A pile of statistics is not going to have the power of a single emotional image. Our patients have barriers to treatment. Our general dentists have reasons that they don't want to send patients to you. This picture here, for those of you in the back that can't see it, it says patient Chad, and it says Dr. McGuire, and I'm holding this ghastly instrument here. I had a little boy bring me this about 25 years ago, the day I was to do a frenectomy on him. Now, I think I may have failed in communicating with him ahead of time exactly what we're going to do. Our patients and our general dentists come to us with barriers. And if you don't deal with these barriers, I guarantee you they will not hear your message. You need to give them permission that it's okay maybe not to want to work with me, that it's okay that you may be afraid. You've got to deal with the barriers first, or they'll never listen to your message. The patient's most common barriers, and these are not things I've made up, there's data for all of this, is time, pain, appearance, and money. Time is the most valued commodity in the United States. Time moved ahead of money in around the mid-90s as far as the most valued commodity. So you have to talk to your patients about these things. Find out, Mrs. Jones, most people have something that bothers them about what we talked about today. Tell me, what bothers you? And you have to deal with these. You have to diffuse them, because even if you're a really good communicator and you can get them jazzed up when you're in the office, when they leave, they're going to go home. They're going to be talking to their significant others. They'll talk to their neighbors. And these things, if you haven't dealt with them, they will resurface and you're in trouble. Same thing with general dentists. Here's the barriers. We steal their patients. We undermine their credibility. We criticize their dentistry, and we use up all the patient's money. Right or wrong, these are perceptions, and if you don't deal with these, you'll never get to the other side. The way we resolve these is first uncover by asking. If it's a general dentist, gee, Sam, what kind of problems have you had with working with periodontists in the past? And they'll tell you. And then use the 3 Fs. I know how you feel. Others have found. I know how you feel. Others have found, and how we're going to resolve this is by linking the objection that we've identified to the feature in your office that's going to overcome that objection, and then strongly tie it to the benefit. And the benefit is the key here. The benefit is the most important thing. And in order to communicate this, we also have to determine what style of patient or general dentist we're working with. Again, this is Communication 101, and most of us do this intuitively, but you can refine your skills if you think about it. One of the different classification systems that I'm aware of stratifies people you're communicating into people who are interested in recognition, romance, self-preservation, or money. If you're talking to somebody that's interested in recognition, you want to help them look better in their own eyes, identify them as an important person. If you're talking to someone who's into romance, you want to help them understand that what we're going to do will provide a fuller, more beautiful, prettier situation. If you're interested in somebody's into self-preservation, those are easier ones. Those people are interested in health and wellness, prevention, doing the right thing, a fear of not doing the right thing. Or people who are into money, you want to talk to them not about money, but by dividends for life, saving money in the future, and by spending a little upfront time. And in fact, the more time you spend with patients before you open their mouth, you'll probably find out things that are far more important toward getting to the end point than what you'll find once you get in their mouth. And so once you understand their style, then instead of if you're working with the patient with these risk factors, instead of talking to them about all these disease risk factors, talk to them about the here and now benefits, and generally not losing their teeth. Everybody thinks they're going to win the Florida lottery tomorrow, but nobody thinks they're going to lose their teeth. It's too far out in the future. Talk to them about things like preserving bone, health, wellness, eliminating disease, fresh breath, enhanced quality of life, peace of mind, make more beautiful, youthful, comfort, self-worth, confidence, sexy, save money in the future. All of these things are here and now benefits. And if somehow you can link the control of these risk factors based on their style and what their interests are, that's how you'll get them to move forward. In a similar way, we need to talk to our general dentists about the benefits of working with us to resolve these risk factors, that it may reduce their overhead, increase their efficiency, reduce liability, increase case acceptance, result in superior outcomes, flexibility to increase scope of practice without substantial capital commitments, and increase happiness and well-being. Focus on the benefits. As we move into risk management, another fortunate thing comes to the surface, and that is wellness is the hallmark. Risk management is the hallmark of wellness. And that's very important because the largest patient base, our biggest customer base out there, values this almost more than anything else. This year, in 2011, the first baby boomers turned 65. In 2020, 1 in 5 of our patients will be 65 years or older, and 2020 is just a few years away. These people, living older is not enough. They want to live better. They value health, they value wellness, and the good news for you and I is they have the money to pay for it. They also bring to us more teeth than any other generation in the past. They're not like their parents who lost their teeth as they grew older. The baby boomers, they've spent their entire life going to the dentist. They value prevention. They value what you and I do, but they also will be living with complex diseases, and risk assessment and risk management will be even more important. Risk management, not only to manage their existing disease, but also to help anticipate and prevent future diseases. And as Dr. Corman mentioned, these patients expect this. Our patients are probably more used to risk assessment than we are as a profession because they're experiencing it as they're growing older. They're experiencing it in oncology. They're experiencing it in cardiovascular work. And so they are seeing this in other parts of their life, and when they come into your office, they expect it, and you should be providing them that for it. It helps kind of place your practice at the leading edge, at least as it relates to what their expectations are. You know, it's almost easier to identify these risk factors. In fact, it is easier to identify these risk factors than it is to control them, isn't it? We in periodontics we do pretty good. We have a good track record of managing plaque control, don't we? You know, we have programs in our office that help educate patients on effective plaque control. We track it. We know what happens over time. But be honest. How many of you out there have effective smoking cessation programs? How many of you out there talk to your patients about weight control, alcohol consumption as it relates to inflammation? How many of you out there really monitor glycemic control, or you just talk to your patients, well, how's your diabetes? You know, everybody says it's under control. The bottom line for most of us is we don't do a good job at this. And there's lots of reasons for it. One is that, you know, we don't want to run our patients off if we're sitting there preaching to them all the time. I like to, you know, I oftentimes tell my patients, I'm kind of like your cardiologist. You come to me, you've got heart disease, I tell you, you need to drop 20 pounds, you need to quit smoking, get your cholesterol down. If you tell me you can't or won't do that, it's not that I'm not going to treat your heart, it just means that the outcome probably won't be as good. And so if we can't do risk factor modification, then we at least need to do expectation modification. And make certain that not only our patients, but also your referring colleagues and the hygienists understand expectation modification. That there's limits to what we can do without the patient's involvement. And as we begin to talk to our patients about these things, again, don't be talking to them about, you know, the disease. Link all of these risk factors to the benefits they're going to see by controlling them. Not resolving the periodontal disease, but all these little things that I mentioned just a minute ago, these here and now benefits. That's how people will move to action. If you look at the brochure for this meeting, it is jam-packed full of fabulous courses to improve your technique. I've been to a whole bunch of them. And it's the focus of this meeting. But the sad news is if your communication skills are not on par with your technical skills, you may not get to use some of these newfangled techniques. Communication, as I mentioned earlier, is not telling. Communication is listening. And it generally takes three things. You got to listen twice as much as you talk. You don't want to tell them everything you know. Periodontists are absolute masters of answering questions that were never asked. And finally, you've got to be able to repeat back to the patient or back to the general dentist what they said in your own words without judgment. Judgment destroys communication. And you have to listen with the intent to understand and not reply. That's tough for me. I catch myself all the time trying to think of my response before the other person's even finished talking. You can't communicate effectively that way. The doctor-patient communication, the doctor-patient relationship is one of the most complex relationships out there. It involves people generally of different statures. It is usually non-voluntary. It involves issues of importance that are generally emotionally charged. It requires close cooperation and trust. I mean, wow. If you think about that kind of environment, it's a difficult situation. And it all hinges on interpersonal relationships. Whether it's with your general dentist or whether it's with your patient, rapport is not enough. It's got to be a relationship. Because communication is around emotional issues, and with rapport you don't get there. You have to have a relationship. Exchange of information is also difficult because as the doctor, our goal is to glean information so that we can come up with an effective diagnosis, treatment plan, risk assessment. The patient has a different goal. They want to understand all this, but they also want to be understood. Doctors are constantly being criticized for over-controlling the consultation, for not spending the time giving the patients the information that they need. You know, hardly anybody's ever sued for not being competent, but people are sued for lack of poor communication. And finally, decision-making. Boy, that's changed a lot. It used to be, if you're talking about the general dentist, that, you know, a generation ahead of me, if you're the periodontist, you're the captain of the ship, and basically you told everybody what to do. Same thing when my parents went to the dentist, went to the physician. The doctor didn't spend any time justifying the disease or the treatment. This is what you have and do it. That's not the way your patients work, is it? Or it's not your relationship with your general dentist, is it? They want empowerment. They want shared decision making. But in order to do that effectively, it requires a lot of information. It requires good listening skills. It requires all of the other elements we talked about. We've got to give all of our patients risks, benefits, and options of all of our treatment. And as it relates to risks, this is not an option. You can't opt out of giving your patients their risks. Risk, that's the cornerstone of informed consent. The good news is that this is information our patients want. There's been an explosion in the interest of health. As is evidenced by the pamphlets, the books, the websites, the TV shows, all on health. There's an insatiable insatiable appetite for health. Same thing about risk. There's a number of companies who have been developed to do nothing but risk assessment and risk management. If you do a Medline search, you'll find far more articles than ever that have risk in their title or in the abstracts. Hardly a day goes by that you don't hear in the media about some sort of public health risk. Risk is out there. And so I'm suggesting seize the opportunity. The time is right. You have a patient population who needs and values risk assessment, and they've got the money to pay for it. You've got two different audiences, and they require different communication skills. As it relates to risk, we've got good evidence that if you have a patient with these negative prognostic factors, they have prognosis with fair, poor, questionable, or hopeless, those people probably are going to need more close monitoring. If you have somebody that has teeth with primarily good prognosis, odds are they're going to do just fine over time. Similarly, with these risk factors, if you have somebody that's a smoker with inflammation, diabetes, history of periodontal disease, or genetic influences, if you have one or two or all of these, strong evidence these people need early referral, careful monitoring, aggressive treatment, and frequent recare visits. Even stronger is the negative. As Dr. Corman said, if you have somebody that doesn't have disease, it's very unlikely they're going to have moderate to severe disease in the future. But this is where it becomes tricky, isn't it? That we can't just give those facts to our patients. That we've got to look and see what barriers they have to treatment. We've got to listen to them. We've got to talk to them about the benefits. So I would suggest dust off these guidelines for the management of periodontal disease. Present those along with the risk factors that Dr. Corman and I have talked about to your general dentist. But don't talk to them about what it's going to do with the disease. Link that into the benefits of how that's going to improve their practice. Similarly with the patients, don't talk to them about how these risk factors relate to their disease process. Link it to the benefits that they want. Not the benefits you're choosing, but the benefits that you have spent time finding out that are important to them. And if you do that, then they'll move to action. There's a lot of confusion out there. There's confusion inside the profession. There's confusion outside the profession. There's confusion because of information overload. There's a lot of confusion about who to even believe. You and I have to be better communicators than we've ever been in the past. We have to be better communicators with our patients, our public, with our colleagues. We have to spend time listening rather than talking. The message should be that clinical signs have little to do with risk, and that appropriate referral and vigilance on our patient's part should be related to risk factors and not the clinical appearance of the disease. We need to make sure that's being communicated as it links to the benefits that are important to our audiences. I think the Academy has done a great job with everything they've done on risk, but this is not something the Academy can do for you. Communication occurs interpersonally. It occurs on the local level. It's not easy, but it's critical if we're going to be effective at communicating risk of periodontal disease both to our patients and our referring dentists. Thank you very much for your attention.
Mike, that was terrific. Now we have some time for questions. And it's hard for me to see here. You come up to the microphones and ask your question.
Thank you. Those were great talks. Dr. Corman, I have a question. Should we be focusing perhaps more on risk assessment in our younger population? We seem to focus so much on our more elderly patients because we're treatment-oriented.
It's a very interesting question, and I think it really perhaps factors in to a great extent to some of the concepts that Mike presented. To a great extent, we want to identify our objectives here as clinicians in terms of risk assessment. Patients come to our office with some problem. We manage those problems, and I think as Mike described integrating risk assessment and communicating risk assessment, we can really apply it to our patients with existing problems very nicely, but certainly with some substantial challenges. Ideally, we would like to do exactly what you say, and that is somehow get to patients early in this process while they're still healthy or have the earliest signs of disease. Whether we can do that in our offices is a real question and challenge at this time. But if we can take what Dr. McGuire described relative to communication to the general practitioner as a means for approaching the younger patients, that to me would be fantastic. So I think we can do it today with the patients we have. We also have to look how we influence, educate, communicate with our referring dentists to move it into that younger population for early identification.
Question over at number one.
Ken, first of all, I'd like to suggest the third audience be the insurance companies. My question is, we know that bladder cancer can develop in smokers, even after they've stopped. Are there any residual risk factors in a smoker who has stopped smoking that we should be aware of?
My familiarity with the periodontal literature would suggest that after a smoker has stopped, the risk for future progression of periodontal disease, and I forget whether it's a 6-month period or a year period, it's certainly not a week, few weeks, but in general, the primary risk due to smoking has been attenuated after they stop in terms of progression of periodontal disease. However, we are just starting to interpret and understand this epigenetic phenomenon. Smoking does cause these biologic changes epigenetically, whether they occur in the periodontal tissue, whether it's somehow integrated with the disease that's already occurred due to smoking, and that causes epigenetic changes. We just don't know. We do know in the population studies that in general, if you look at people who have never smoked, people who are current smokers, and people who have smoked for a certain amount and then stopped, that the people who've stopped smoking still have some level of residual risk. We're just not sure what that's due to. And my guess, similar to the bladder cancer story, is that more and more we're going to find that it's due to biologic changes that have integrated somehow in the tissue.
The back microphone.
Thank you for wonderful presentations. I'd like to ask about the family history of periodontal disease. I find that a lot of my adult patients don't know whether their parents had periodontal disease, but some do. And also, I usually suggest to my patients who are parents of children, especially teenagers, to go home and check to see what's going on. And often they diagnose periodontal disease before dentist does. I wonder if you could comment on family history of periodontal disease.
In general, there does appear to be a major genetic influence in terms of at least moderate to severe periodontal disease. How that can be interpreted from a family history, quote, when you get on questionnaire or communication with the patients a family history of disease, is very hard to sort out. And that's for multiple reasons. One, as you point out, many times people just are not very good at communicating. Even when you ask questions appropriately, perhaps they don't know the family history of periodontal disease. So I think, for starters, that's a challenge. I think the other challenge is the genetic influence appears to be probably caused by multiple genetic factors in a complex inheritance pattern. So it's not a simple linear type of conclusion the way it would be with a major genetic disorder.
Front microphone. Front microphone.
Thank you, Dr. Rose. Again, thank you so much, Dr. Kornman and Dr. McGuire, for outstanding presentations. I think I'm reminded, and those of you who perhaps graduated from dental schools in the 60s and 70s may remember a gentleman by the name of Bob Barkley, who came through at a time when awareness of plaque control and bacterial causation of inflammation was just starting to become a major concern to all of us. The problem at that time, however, was how do you educate the dental profession about bacterial plaque, and it's important to teach patients to remove it. The so-called plaque control programs that Dr. Barkley advocated were very ambitiously set up by a number of practitioners who found out very quickly that this didn't work. Even though the outcome of disease control could be very effectively achieved, the problem was the patients wouldn't do it. So it was on that platform, as my recollection serves me correctly, that people like Omar Reed and Ken Barkley got together and brought to the front for the dental profession of the need to listen to your patients. Listen to your patients, create a high-trust, low-fear environment, and then you have a small window of opportunity to transmit your message to a listening ear. Now we jet ahead to current times. We're not focused in on bacterial plaque, but we're focused in on the universe of risk factors. But we're right back to the same situation that we were then. It's funny how the pendulum swings. We've got to reintroduce into the awareness of our colleagues the need to listen. The psychology of communication really seems to be the key to success once again. Thank you so much.
Thank you. Back microphone.
Thank you very much for this excellent presentation. Just had a question for Dr. Kornman. Is there any specific nutritional supplements that you recommend?
No, there aren't. I wanted to just really make a few points relative to nutrition. The first is that there does appear to be some influence based upon nutrition that is very different from the way we thought about it previously, which was more in terms of a deficiency phenomenon. Although the vitamin D story, which I showed today, does speak to the deficiency effect. So I think the first point is there does seem to be increasing evidence to support a role for nutrition very different than the way we originally envisioned. That's, however, challenging to go from that statement to the statement of what can I do for my patient that might make a difference. And I think at this point in time, we're still not quite there, but we might really consider a few things. I think this vitamin D story is becoming compelling from two perspectives. One is there's no question there's a tremendous deficiency problem in the world today, especially the United States and parts of Europe, in terms of major segments of the population that are vitamin D deficient. We know this has multiple effects that appear to relate to periodontal disease and especially response to treatment. So I think it's worth, again, our thinking about risk factors to start looking at how we can more aggressively monitor certain patients. And there are very standard blood tests today to evaluate vitamin D deficiency. That's, to me, I think, justified as starting down that path. Beyond that, I'm not sure that we have much guidance at the moment.
Thank you.
Thank you. Again, thanks to both of you. It was a great presentation. In reference to a comment made just previously that we definitely have to focus on communication, which is absolutely true, we don't necessarily just want to throw away the bacterial aspect of things and say that's not important either, as far as plaque control and so on and so forth. Because plaque, we know, causes inflammation. It was stated very clearly today that you can have periodontal inflammation. You may not have periodontal breakdown, but you may have periodontal inflammation. And the question I bring to both of you is, inflammation, as was evidenced in that article in the 2004 Time magazine, can cause problems systemically. And I don't think it's something that we want to say isn't important. Oftentimes I hear my students come to me and say, well, the patient only has gingivitis. Like, okay, that's not very important. And I ask you both your comments about the degree of inflammation. Is periodontal inflammation more systemically harmful to the patient than gingival inflammation? Thanks.
My perspective on it is certainly I don't think that anybody's suggesting that we forget about plaque. Plaque is very important to control, and in my practice, no level of inflammation is acceptable. I have tons. That said, I have tons of patients with that we fight with inflammation. I've been in practice for 32 years. I have a big maintenance population, and we struggle with patients on our maintenance program as to residual inflammation. And before we began worrying about inflammation, it wasn't as big of an issue as it is, at least with us now in our practice, that I am accepting less inflammation than I used to, because I used to think, well, it's really not hurting all that much, and you, as a clinician, you're weighing, do I want to go in and do more aggressive treatment? But our goal is to have everybody, inflammation free. Dr. Kornman can speak more to whether or not gingival inflammation systemically is any different from periodontal inflammation. I would think not, but more just on how much inflammation that you have. That's kind of my feelings on it as it relates to a clinician.
Yeah, I concur with Mike and with your comment. We don't in any way want to de-emphasize the bacterial role in this. That's the causative factor, the initiating factor, what keeps it moving. We do want to continue to communicate effectively the way I think we've learned and taught others to do, that bacterial control is the starting point for all of this. And I currently think of the gingival inflammation to some extent as being a very good indicator of how well the patient is chronically controlling the bacterial challenge. We know that the gingival response is a very good reflection of the consistency of plaque control. So I look at the gingival inflammation partly as an indicator of bacterial success in bacterial control. I do draw a distinction in terms of the difference between the moderate to severe periodontitis patient versus the individual with mild disease. And I don't know how to explain those differences except by some of these risk factors, but I do personally believe, based upon the evidence today, that you don't generally see a systemic inflammatory effect from periodontal disease unless you've moved into the moderate to severe periodontitis category. So I think in general, gingivitis and mild periodontitis do not seem to alter measurably the systemic inflammatory burden.
Thank you. We have time for two more questions. The my right front, my left back.
Back to nutrition. There's been some discussion about the role of coenzyme Q or benefit of coenzyme Q in periodontal disease, and there's a number of supplements out promoting that for periodontal disease. What's your feeling about that?
You know, I've looked at that over maybe 20 years in terms of people discussing coenzyme Q. There's no question that there's a change in the CoQ10 levels for people taking statins. And so I know from a medical standpoint, some physicians recommend supplementation for individual taking statins. To this point in time, I'm not personally overwhelmed by the strength of the data suggesting there's a relationship to periodontal disease.
Question.
Concerning epigenetics and the turning of a fibroblast into a different looking fibroblast, can we not change that again? If it's been damaged, can we not, if it's epigenetic, actually affect it once again and get a new fibroblast, maybe one that's healthy again?
It's an excellent question, and as we're learning, there are multiple types of epigenetic influence. Some of them are very reversible, and others less so. And so one of the possibilities with epigenetic changes, which may be occurring with fibroblasts, is not only, we know that within a fibroblast population there are subpopulations. And we're not, and we know how to characterize those. We're not totally sure whether they're long-lived or whether they can move, among themselves or not. Some indication that they can. So your question, I think, is a very important one, and I believe there are data in the periodontal literature. Klaus Lang's group, I think Roy Page at various times, have looked at the fact that with really chronic, good inflammation control in the tissue, you do start to change long-term that tissue effect in some way and some of the behaviors of the tissue. So it may well be that some of this is reversible. We just really don't know at the moment. There's a lot more. It's still a lot of hypothesis, a lot of theory, but certainly out of the rheumatology space, with some very relevant data to our field, it's starting to look impressive.
Thank you.
Thank you very much. Ken, Mike, this has been 2 hours of excellent teaching. Thank you very much. Wonderful.